I have, there's some material in here I promised I would never give on DVD. But yeah, you break promises in life, don't you? So some of the material that I'm going to present to you towards the end is going to be a bit troublesome. And I've only shared this with people that I've known quite well. So I guess I'll have to include you in that group because I'm going to share it with you. And part of this is part of a presentation I gave to the American College of Lifestyle Medicine. When I gave that presentation, which also included the first night presentation that we did on heart problems, part of that information was there. When I was asked to give the opening speech for the American College of Lifestyle Medicine, I refused because I said this will set the tone for the college. And you won't really want to be associated with what I have to say and with the seriousness of what I say for that presentation. Daryl and Normal were at that presentation. And there are several other people that were there. And I spoke in front of an audience of 80 professionals. And I've only heard negative feedback from one of them. But there may be more that regretted that I gave the presentation as I did. So if you combine Friday night's lecture with what I'm going to share with you right now, you have a fairly good idea of what I told many of my colleagues. Lifestyle medicine is really where it's at. That's what really works. Unfortunately, lifestyle medicine is largely nonprofit. It's mainly an education. It deals with very low-tech things. And as a result, it's not been very successful. Lifestyle medicine dates back a long time. One of the earliest and the most important references that I've seen from lifestyle medicine comes from the Bible, from Daniel. He tells a story about his men living in the king's castle, becoming sick, and he asks the gatekeeper, can we do an experiment? Can we put my men on pulses and water, which is vegetables and water? Now, granted, it wasn't a double-blind, placebo-controlled study. But they put them on pulses and water, and they reported in 10 days that those who changed to the vegetable diet were much healthier than those who continued with the royal food. Now, this has to be a true story. It has to be of great relevance, or it wouldn't have survived for 2,500 years. Lifestyle medicine, and it takes 10 days. That's, I guess, why we run a 10-day program. I have many heroes. I stand on the shoulders of many, many people, like Russell Henry Chittenden, who's the head of biochemistry at Yale for 30 years. Russell Henry Chittenden was concerned about the recommendations for protein back in the late 1800s. What was recommended back there were similar protein intakes that are recommended today, 135 to 185 grams of protein per day per person. The way they established those levels was through observation. People like Carl Voigt and Charles Atwater, they observed what people ate, and they made the assumption that what people ate had to be intuitively correct. So when they observed people that had choices of many kinds of foods, they found out that they ate a lot of meat. So they assumed that by nature, people would choose the right thing. And so they calculated how much protein was in their diet, and that was established as the correct protein intake for the human being, just based upon bigotry, upon bias, upon observation. You know how well your friends and relatives innately choose the right thing to eat. Well, Russell Henry Chittenden, he said, I don't think that's particularly right because of the fact that I've seen people in Central America and South America who live on virtually no meat, and they work hard and they are very active and have normal-sized adult skeletons. I have friends that are vegetarians, he said, who thrive on a healthy diet that contains very little or no meat, essentially no meat. So he decided to test really what this diet thing was about, particularly in terms of protein. And so he cut his protein intake from around 150 grams a day to about 40 to 60 grams a day. And he lost weight. He lost about 30 pounds. His daily sick feelings went away. His arthritis in his knees disappeared. Now, he started with himself because he was worried that maybe he would hurt somebody with this low-protein diet. But he found out that he himself thrived. And so what he did next is he took 5 of his Yale faculty members who were sedentary. Didn't want somebody with very much activity. 5 Yale faculty members, put them on the diet, same thing happened. They lost weight, their aches and pains and problems went away. And then he tested a little further with people that are a little bit more active, and he took 13 hospital corps people from the U.S. Army who were physically active all day long. They worked in the field, and one day a week they got very, very active. Put them on the diet. They all thrived, lost weight, aches and pains went away. And the ultimate test was he took 8 Yale athletes, Olympic quality athletes, put them on the diet. They didn't lose weight, but they improved their athletic performance by 35%. He published this in 1903, more than 100 years ago. Lifestyle medicine. And he did scientific tests, the best tests available today, careful dietary histories, urinalysis to determine what happened to these people, not just making an observation of what folks eat, and that must be correct because people would intuitively choose the right kinds of foods. Russell Henry Chittenden is one of the people whose shoulders I stand on. Walter Kempner from Duke University, the rice diet. Many of you have heard of the rice diet. It was the most popular, even the most economically important thing about Duke University up until recently. Walter Kempner came to Duke University in 1939 with the idea that feeding rice and fruit to people would improve their health. By the early 1950s, he had published in the scientific journals and had lectured to doctors and lay people across the country about all the things that I'm trying to teach you. He had shown that people with severe hypertension, I'm not talking about the kind that you and your friends have and relatives have. I'm not talking about high blood pressure of 150 over 100. I'm talking about people with blood pressures of 240 over 160. That he could get these blood pressures down to normal 60% of the time with a diet of rice and fruit, and then maybe some vegetables later. That he could stop rheumatoid arthritis. That he could reverse EKG changes in half the people that he took care of. He could shrink swollen hearts to normal size half the time. Reverse diabetic eye changes. Reverse diabetes and make blood sugars normal. Drop cholesterol, triglycerides, all the things that we've talked about. And Walter Kempner published this in the early 1950s. One of my heroes. Roy Swank, another one of my heroes. Roy Swank served as the head of neurology at the University of Oregon Medical School for 23 years. He made some observations during World War II. It was his job when he was in the war to observe what happens to people's health. And he found out that in Western Europe, people became healthier as food became less rich because of the occupation of Western Europe by the Germans. He found that there were fewer new cases of diabetes. People with diabetes had fewer complications, fewer new cases of multiple sclerosis, and people who had MS stopped having attacks. Heart disease almost disappeared in Western Europe. In a time of tremendous stress, I mean, imagine people shooting at you, locking you up, taking away your liberties, and they got healthier. So Roy Swank took that information after the war back to his university studies, and he started treating people with multiple sclerosis. He has treated 5,000 people over a 50-year period of time with a healthy, low-fat diet with multiple sclerosis. He's published 176 scientific articles. He has never been questioned as far as the validity of his information. No one's ever come out with a study that says Roy Swank's work does not work effectively, the dietary change. He's published in our major medical journals. And what he says is that if you follow a low-fat diet, that over a 35-year period of time, you have a 90% or better chance of being the same or improved if you have multiple sclerosis. Now compare that to the fact, the scientific fact established by many studies. If you have multiple sclerosis and you're on the most expensive, quote, best drug therapy available, within 10 years, half the people are unable to walk, unassisted, wheelchair-bound, bedridden, or dead. In 10 years, half the people. Best, most expensive drugs out there can't improve upon that data. Yet, Roy Swank's data has been published since the early 60s, has been confirmed over and over again by his publication, and he was the head of neurology at the University of Oregon Medical School for 23 years. One of my heroes. The fiber man, Dennis Burkitt. Dennis Burkitt changed my life. I was a senior in medical school, and I went to a noontime conference. Most noontime conferences to me were well beyond my understanding. I went to learn about how to take care of people, how to cure their problems, what caused their disease, and they talked about signs and symptoms and symptom relief and sign relief. Nobody really talked about what caused these chronic diseases. It was very frustrating for me as a young medical student. Then Dennis Burkitt showed up. Dennis Burkitt was a surgeon. He was trained in Edinburgh, Scotland. After becoming a full surgeon, he moved to Uganda. and went with some of his friends, fellow colleagues, fellow doctors. They went to Uganda. He eventually became the head of the Ministries of Health of Uganda. And he had access to the whole population, their health data, their health care in Africa, in Uganda. And so after his experiences, he went around the world lecturing about the importance of a healthy diet, an African-type diet in terms of our chronic diseases. And he came to my hometown where I was doing my medical school training in Grand Rapids, Michigan. He was there to talk to the people at Kellogg cereal food company in Battle Creek. He wanted to convince them to put more fiber in the food. And Dennis Burkett, at that noontime conference, told me that there was a cause of these chronic diseases. He told me when he was in Africa, 15 years, he saw no cases of hemorrhoids, no varicose veins. He saw no diverticulosis, no deep vein thrombosis. He saw one case of gallbladder disease. He saw no obesity. He saw one heart attack, and that was from a judge who was trained in London and came back to Uganda. Essentially no diabetes. All the problems that I was involved in as a trainee medical student. And he said these things didn't occur in these underdeveloped countries where they ate largely a plant-based diet. He opened my eyes. He's known as the Fiber Man. Nathan Pritikin, another pioneer whose shoulders I stand upon. Nathan Pritikin popularized the idea of a low-fat, plant-based diet. Nathan Pritikin said, I think it's ironic that the health agencies responsible for protecting our health are in effect destroying our health and shortening our lives. 1.5 million people are dying each year prematurely because their food supply is poisoned with excess fat and cholesterol. And he told people this in the mid-70s. And yet, what long-time influence did he have? And then, of course, you had the opportunity to personally meet Dr. Dean Ornish, who is another pioneer who has made huge changes in the way people think about diet and lifestyle. What an opportunity that we've all had this weekend. Dr. Dean Ornish says, I don't understand why asking people to eat a well-balanced vegetarian diet is considered drastic. Well, it is medically conservative to cut people open and put them on cholesterol-lowering drugs for the rest of their lives. Yeah. I mean, what's radical? Eating potatoes and beans and rice and minestrone soup and bean burritos? Or charging somebody $60,000 to put a hole in their chest? Okay, so why isn't, I mean, look at this long history, thousands of years, and certainly over the last 100 years, it's been well established by some of the most important thinkers that a healthy diet is the solution to healthcare problems. Why has this not become profitable? Well, I don't really know the answer, but I'll give you some of the conclusions that I've come to. It's low profit. That's the big problem. And it takes some patient effort. It's not high tech. And it takes control of healthcare away from the providers. Yeah. It gives it to you. Now, I want to be perfectly clear that medicine succeeds when it comes to acute care problems. We get a big A when it comes to things like infectious diseases, trauma, and we don't want to lose sight of the fact that we've made great accomplishments. But when it comes to chronic disease, I mean, just the word chronic, what does it mean? It means we've failed. It continues or continues to get worse. So just the terminology declares that we have not succeeded and there's great room for improvement. Where we've succeeded is in terms of sanitation, immunizations, antibiotics, surgeries, trauma surgery, and you certainly want to take advantage of those things. You don't want to take the attitude that all problems are solved by a good diet, exercise, and clean habits. That's just not true. But about 80 to 90% of problems are. Chronic disease accounts for 3/4 of the healthcare dollars spent in this country. They're dollars spent on cancer and heart disease and strokes and diabetes and other forms of atherosclerosis. That's where the major money is being spent. That's where our attention needs to be laid in terms of solving the healthcare crisis in this country, is to solve the chronic disease problems. And we have the knowledge to do that. The pioneers that I just shared with you knew about these things, knew how to solve these problems. It's not for lack of information. It's not for lack of scientific research. It's for lack of motivation to put into play the things that we already know. The treatment of chronic disease with medications can't possibly work. And I want to talk about medicines for just a minute. It can't possibly work. I mean, after all, chronic means forever. as long as you live, let's say. Let's take a look at the problems that we have in our society. Most people after the age of 35 have one or more risk factors that says they're going to live less well and less long. 1/3 of people have elevated cholesterols, most are inactive, 1/3 have hypertension, 30% are obese, 65% are too fat for their own health, and 10% have diabetes. These are diet and lifestyle problems that are caused and solved by changes in diet and lifestyle. But that's not how we approach the problem. I've been in the practice of medicine for nearly 40 years, and in all the time I've been in the practice of medicine, I have to tell you, I have never, ever seen anybody die of high cholesterol. I can't even imagine what death from high cholesterol would be like. I've never seen anybody die of high blood pressure. The only thing I can imagine, have you ever seen the movie Scanners, where people's heads shake and they explode? It's a scientific picture. I've never seen anybody die of high blood pressure. And I've never seen anybody die of high blood sugar ever in my whole career. And I don't know anybody else that has. We can treat these signs of disease, these high cholesterols, high blood pressures, high blood sugars, we treat those with medications very effectively. And we can lower cholesterol, we can lower blood pressure, we can lower blood sugar. There's no question about that. But these are signs of disease. These aren't diseases that people die from. The reason that drug companies treat the signs is because they're very capable of doing that with medications, but they can't treat the underlying issue. What do you care if your cholesterol is 300 as long as your arteries are clear? Or your blood pressure is 170 over 110 as long as your blood vessels are healthy? What do you care? You just want to stay alive and healthy for a long period of time. Now, it is true that having these signs elevated predicts that that's not going to happen. But the attention should not be directed at the signs because it doesn't solve the underlying sick arteries and sick tissues. What do people, even though these drugs are very effective, what do people die of that have high cholesterol, high triglycerides, high blood sugar, and high blood pressure? I want you to think about it for a minute. I talk to quite a few medical groups, and medical doctors have on their desk one of these books. It's called a Physician's Desk Reference. And the Physician's Desk Reference categorizes medications. For example, they have a category called anti-infective medications, antibiotics. And antibiotics cure disease, yes? Marvelous inventions, antibiotics like penicillin. Cures disease, they're miracles. I ask my medical audiences, and any of you who are doctors in this audience, I'll ask you, we have another category of disease. These are called anti-diabetic agents. These are diabetic pills. How many of you have known patients who have been cured of diabetes with anti-diabetic pills? Now, I've never had a doctor raise their hand and say, yes, we give anti-diabetic pills all the time and it cures diabetes. Never happened. So why do you keep prescribing these things? You know, I can understand prescribing anti-infective agents because they cure microbial infections. But if anti-diabetic agents don't cure the disease, why do we keep prescribing them? How about antihypertensive? Anybody seen anybody with high blood pressure put on antihypertensive medications and be cured? Neither. So why do we keep prescribing them? Why is that our emphasis? Why isn't that the last thing we do instead of the first thing we do? You arrive in the doctor's office, your blood pressure is up. On one visit, you're put on a lifetime of antihypertensive medications. That's the general practice. The answer to the question is this. People with high cholesterol, high blood pressure, high blood sugars, they die of rotten arteries. They die of failing tissues, and that's where we really need to direct our attention, but as I've mentioned over and over again, that's not where the money is. But that's really where the problem is and what the solution is, what you want. You want to live long. You want to live healthy. The solution to the problem is lifestyle medicine. We correct these problems with a plant food-based diet, moderate exercise, and clean habits. Let's talk about the treatment of high blood pressure for a moment. Treating high blood pressure accomplishes several things. Treating high blood pressure with medication lowers the blood pressure, no question about it. It does not reduce the risk of dying of heart attacks. That's what the scientific research says, and the reduction of strokes is minimal. I'll give you the data for that in a second. And it does have a lot of complications that cost money. Now, a lot of the research, in fact, most of the research that's been published on using antihypertensive medication has used endpoints that you really don't care about. The endpoints the results that you care about is how long am I going to live with good function. But what they report on is how effective the drug is in lowering blood pressure. That's incidental. You want to know how long I'm going to live and how well I'm going to live and how much I'm going to avoid disease. That's what you want to know from these pills. But what the drugs really do is they reduce a sign, not solve the problem. If you look at the risk reduction for treating high blood pressure, what you find is over 5 years, the absolute risk reduction is about 6 strokes in 1,000 people. In other words, by taking high blood pressure pills, you get 1 stroke less per year by treating 1,000 people with medication. Is that something to be proud about? Is that something to be proud of? I don't think so. You don't reduce the risk of dying of heart disease. That's nothing to be proud of. You cause a tremendous amount of expense and side effects, and you also divert people's attention from what will really make a difference. I see people all the time. I ask them, do you have high blood pressure? They say no. Well, wait a minute. I see your list of medications. Well, I used to have it, but now I don't have it anymore because I'm on all these pills. Well, do you have high cholesterol? No. Well, you're on Lipitor. Yeah, I don't have high cholesterol anymore. You see, it diverts them. They think they have solved the problem. The drug companies have expanded the definition of sickness to increase the market also. It used to be that high blood pressure back in Walter Kempner's day was 240 over 140, or 200 over 140 back in Kempner's day. The British guidelines, which is the most current recommendations on treating high blood pressure, say that you should start treating high blood pressure if the blood pressure is 160 over 100 or greater for months. But in this country, they tell us we should treat high blood pressure if it's 140 over 90 or greater. And there are now recommendations that you should treat high blood pressure if it's 120 over 80 with medication. We should treat people even who have blood pressures of 110 over 70, people who are pre-hypertensive. Now, the motivation for doing this is marketing. It's to sell more medications. The British guidelines, which are the most current of all recommendations. The British guidelines, if you read the report in the 2004 issue of British Medical Journal, what they conclude is that all people with high blood pressure, borderline or high normal pressure, should be advised on lifestyle modifications. But that's not how medicine is practiced. And then they say we should initiate antihypertensive drug therapy if the blood pressure, systolic blood pressure, is 160 millimeters of mercury or greater, and the lower number or diastolic pressure is 100 millimeters or greater. But I assure you, most of the people I take care of with high blood pressure has been put on blood pressure medication for pressures far lower than this, and usually after one reading. And then what we do to increase the market, and this has been accomplished from the pressure of the pharmaceutical companies, is we set goals for treatment that end up hurting patients. What most doctors believe, and it's not based upon good scientific evidence, but upon the teachings of the drug companies, is that we should make people normal who have high blood pressure. And normal being 110 over 70 or later, but we do, or lower, but what we do is we end up hurting these people by being so aggressive with the treatment of high blood pressure. Scientific research, multiple studies, including studies that have been published this year in the Annals of Internal Medicine, show the following. When people have high blood pressure, and in this particular slide what I'm showing you here is people whose diastolic, or in other words, lower number is 120 millimeters of mercury, it helps them by giving them medication and lowering their blood pressure up to a point, and that point being around 95 millimeters of mercury. And then what happens as you more aggressively treat these people, their risk of dying increases. So the lower you make their blood pressure, the higher the risk of dying. This is called the U or J-shaped phenomenon of mortality. Now, the reason this happens is the blood pressure is up for a reason. The body doesn't make mistakes. When you eat a rich diet, you end up clogging your circulation. You end up sludging the blood. You end up creating spasms in the arteries and all kinds of blockages. And as a consequence, you increase peripheral resistance, the resistance to the flow of blood. So the heart responds by increasing the flow of blood to the tissues, and the way it does that is by increasing the pressure. It's a normal, natural thing to do. It's what's supposed to be done. You have to get oxygen and nutrients to the tissues. So because of this clogged up system that you have, the body responds properly and raises the pressure. So what happens next is the doctor comes in and gives, and I hate to use this term because some of you will react to it, but it is the proper term, gives poisons to inhibit the action of the body and prevent it from doing what it's supposed to do. So we give beta blockers that take and prevent the adrenaline in the body from working on the heart muscle. We give medications that cause the body to lose fluids, diuretics. We give medications that paralyze the constriction of the arteries, the calcium channel blockers. And as a consequence, we counteract these natural mechanisms that the body tries to cause to raise the blood sugar and deliver nutrients to the tissues. Well, when we give these medications, what we end up doing is we decrease the perfusion pressure to the heart muscle and other tissues, and as a consequence, people die. You actually triple your risk of dying by aggressively treating high blood pressure and lowering it down to what people consider normal. So, if somebody has a high blood pressure, I'll treat them. In other words, if for months they have a blood pressure of 160 over 100 or greater, I'll put them on medication. But when I do, my goal is to drop their blood pressure to a level that won't cause them to have an increased risk of dying, which is, say, a blood pressure with a diastolic of 85 or 90. But that's not usually how medicine is practiced. The way you really want to take care of this high blood pressure problem is you want to take and reduce the factors that are causing the blood pressure to go up. You want to change the diet. The DASH study has shown that if you change to a vegetarian kind of diet, more plant foods, less animal foods, what happens is you end up lowering blood pressure. You also decrease cholesterol and you cause people to lose weight. One report on the importance of diet and lifestyle says a diet low in sodium, high in potassium, rich in fruits and vegetables, whole grains, cereal, fiber, and fatty fish will likely reduce the incidence of stroke. So this is a conclusion that's out there, but unfortunately it doesn't have much stimulation to be popular. When we treat diabetics with pills, we do cause some things to change. The endpoints for treating type 2 diabetes is we do lower blood sugar erratically. It's a very difficult thing to treat somebody with type 2 diabetes, I have to tell you. It's very frustrating as a doctor. You give them insulin, you give them diabetic pills, their blood sugars are 300, they're 330, they're 110, they're 60, they're 180, they're up and down, up and down, up and down. And unfortunately, the patient feels guilty about this. They feel like they're not taking good care of themselves. I have yet to see a doctor who can take a really, truly diabetic person and with medication make those blood pressures just the way they ought to be. It just doesn't happen. Even though they sincerely try, it just doesn't happen. So yeah, you can lower the blood sugars, but you don't do it very effectively. Do you reduce the risk of dying of heart disease? No, you do not. Do you cause people to lose weight, which is a risk factor for heart attacks related to diabetes? No, you cause them to gain weight. The average weight gain when you put somebody on diabetic pills or insulin is 20 pounds. Well, here's what the situation is. This is the sad thing about being a diabetic. You go to the doctor. Doctor says you got diabetes. You say, oh no, doctor, what should I do? The doctor says you got to take these diabetic pills, and I want you to lose weight. So you go home, you try and lose weight, you take the diabetic pills, which by the way are insulin, which forces fat into fat cells, or types of diabetic pills that actually raise insulin in the body, which forces fat into the fat cells. You go back to the doctor the next month, the doctor looks at you and says, get up on the scale. The doctor says, hey, you gained 8 pounds since I saw you last time. I thought I told you to lose weight. Now that you're heavier, your diabetes is worse, I have to put you on more medication. Now I want you to come back next month, and I want you to be trimmer. And you come back next month, and you're heavier, and your diabetes is worse. And you get into this vicious cycle. And everybody feels bad about it. The doctor feels bad about it. The patient feels bad about it. It just plain and simple doesn't work. And so one of the first things that I do when I take care of a type 2 diabetic is I take them off their medication so we can change that cycle. They start losing weight, which their doctors have told them to do all along. Does it cause complications? Yes. Treating type 2 diabetes causes complications. In fact, it says so in the PDR. Every physician's desk reference book that has been published since 1972 contains this warning for diabetic pills. It says right here in heavy black print, special warning on increased risk of cardiovascular mortality. And it says if you take these pills, it'll increase your risk of dying of heart disease by 2.5 times over a 5 to 8 year period of time. That's been published in every PDR since 1972. Every doctor is aware of this. It's the only 2 paragraphs in heavy black print in the PDR when it discusses diabetic pills. The particular villain here are medications called sulfonylureas. They cause people to gain weight, and they increase the risk of dying of heart disease. If you look at the major studies done, they show the same thing. This is the diabetic control and complication trial. The largest trial ever done. It's with type 1 diabetics. 6.5 years of intensive therapy for type 1 diabetics. The results, compared to people treated less aggressively, more weight gain in those treated aggressively. More high cholesterol, a higher increase in LDL cholesterol. Triglycerides and the blood pressures were higher in those who were intensively treated. Let's take a look at another one of the major studies. Veterans Affairs Cooperative Study in Glycemic Control and Complications of type 2 diabetes. Type 2 diabetics in this study had a history of heart disease. Those treated with insulin or diabetic medications had an increased risk of death. Let's take a look at the largest European study done, the TRACE study. Diabetics with a history of heart attacks treated with diabetic pills or insulin. The results, almost twice the death rate as those treated with diet alone from this aggressive kind of medication therapy. Diabetics treated without medications, diet only, had the same rate of death as people without diabetes at all. This is the information that's in the scientific literature, yet that's not the way medicine is being practiced. And the reason is because of the money. Diet and lifestyle changes. You can reduce the major risk factors for type 2 diabetes with a diabetic change. You can cause them to lose weight. You can improve their insulin resistance. And as Dr. Neil Bernard shared with you, you can also take people with type 2 diabetes and you can get them off medication and increase the health of these people by reducing their blood sugar levels and coronary risk factors. In our experience, somebody asked this question, in our experience it has been that we can get most people, and I'm talking about well over 90%, and by the way, this was also the findings at the University of Kentucky Medical School, the endocrinology department that they published in the research literature. You can get at least 2/3 of the patients on insulin who are type 2 diabetic off of all of their insulin, and well over 90% of those people who are on diabetic pills off all their diabetic pills, and they'll be better off than when they're on the medication. So this, again, is research that's been going on for an awful long period of time. The use of a low-fat vegetarian diet in patients with type 2 diabetes was associated with significant reductions in fasting glucose concentrations, body weight, and the absence of recommendations to exercise, and that's Dr. Neil Bernard's work originally, which he's republished just a couple of months ago. Let me explain to you how people are treated, and let me explain to you based upon an experience I had several years ago when I was at St. Helena Hospital. I don't go to noontime conferences very often because noontime conferences are sponsored by one pharmaceutical company or another. They buy the doctor's lunch, and fortunately there are many universities around the country that are banning this practice. Their students, their faculty can no longer accept free pens and prescription pads. Of course, the doctors say these are never of any influence. They can no longer buy the doctor's lunch or trips or opera tickets, or they can't do this because they know that this is graft and corruption. Well, most hospitals still have these noontime conferences, and I didn't usually go because I knew what the intention of these conferences was to sell me various drugs for my patients that I knew the results of. But I was persuaded to go to one noontime conference, and it was a conference whose title was Diabetes is Caused by Fat, Not Sugar. And I said, oh boy, finally somebody's got it right. Let's go to this conference. And I gathered my whole staff together. We went down to the lunchroom, and I walked in, and my first clue that there was a problem was the drug detail rep was sitting in the back room. And then the next thing that happened was the speaker walked in, and he was obese with greasy skin, pimples, and a ponytail. But I said, oh, you know, I got to stay. It could happen. Finally, somebody could have the right message. Didn't want to judge a book by its cover, so to speak. So I sat and listened, and I listened to this man lecture about how to properly take care of somebody with type 2 diabetes. And soon I started jotting down the medications that we were supposed to use. And when I got done, I found out that proper treatment of a diabetic was with about 20 different kinds of medication. Something for cholesterol, something for the diabetes, something for the peripheral resistance, etc. Well, he got done with this lecture, and I raised my hand, and I said, sir, I said, the title of your lecture is Diabetes is Caused by Fat, Not Sugar. I said, I listened to your lecture very carefully. I didn't hear you mention diet once. Did I miss something? He said, no. I got you here, didn't I? I said, yeah, you got me here. I said, but a lot of the medications that you're recommending, such as the sulfonylureas and the calcium channel blockers, have been actually shown to kill people, to dramatically increase the risk of dying of heart disease. How can you make these recommendations? About that time, the head of the health center stood up and apologized for my behavior. Yeah. He said, well, Dr. Mcdougall, you don't know him, but he's very interested in health food. So I figured I'd said enough. And we're walking out of the room, and I'm walking next to my colleague. His name is John, and we'd known each other for many, many years. And I said to John, I said, you know, our colleagues don't really believe this. They don't believe that's the right way to take care of a diabetic, do they? And he looked at me and he says, yes, we do. And that was one of the deciding moments when I concluded that it wasn't in my best interest to stay associated with St. Helena Hospital, which I'd been associated with for 16 years. And then this lecture, I have to tell you, to make all the doctors feel good about what we were doing, he gave a really sexy term to what we were practicing. He called it polypharmacology. Yes, that's what we were practicing. Now, doesn't that sound like a really high-tech, desirable thing to do, is practice polypharmacology? So what it turns out is the well-treated patient, and when I see patients, they're not on one medication. They're on a bag full of medications. A well-treated patient has something for their blood pressure, something for their blood sugar, something for their cholesterol, like Lipitor, something for their uric acid, for their homocysteine, they take folic acid, for their triglycerides, they take Lopid, something to thin the blood. You can't take cheap aspirin anymore that you get 30 for a penny. You've got to take $4 aspirin called Plavix. Something for the body fat, something for the body aches, headaches, indigestion, constipation. You treat the constipation, you commonly get diarrhea, so you have to be able to counteract that, so you give something to the diarrhea. And then, of course, you have to give something to cover up all that bad smell you get from the food. So perfumes and deodorants and so on. So this is what the well-treated patient looks like according to the standard practice of medicine. I want to introduce you to one of these people. This is a patient. He wasn't a patient here in this picture. This is a picture 2 years prior to him becoming a patient, and this is a true person that I'm telling you about. He had high blood pressure, type 2 diabetes, high cholesterol, high triglycerides, gout, mild kidney failure, overweight, osteoarthritis, constipation. He was depressed. This is a well-heeled man. He's a very wealthy guy. And he went to the doctor faithfully every month and followed the doctor's instructions. Took all of the doctor's recommendations to heart, followed them just the way that he should. And 2 years later, I had a chance to take another picture of him. And here's his picture 2 years later. Okay? Do you see the difference? The difference in this man. Let's talk about this for a minute. He still has high blood pressure, type 2 diabetes, hypercholesterolemia, hypertriglyceridemia, gout, mild kidney failure, overweight, mild osteoarthritis, constipated, and depressed. What is the difference between 2 years of intensive therapy? The answer is nothing. He's still fat and sick. Now he's just carrying around a bag full of drugs. That's the only difference. And I want you to stop for a minute and think about your friends, your family, your colleagues who went to the doctor with good intentions, spent hard-earned money to follow the recommendations, and what did you see change over a year, 2 years, 5 years? Nothing. They're still fat and sick. They have a smaller wallet and a bigger bag full of drugs. Now, stop me if that's not the case. Why would anybody want to practice medicine that way? Let's talk about cancers for a minute. We've talked about heart disease. Let's talk about cancers for a minute. And this is the tough part of the lecture. The treatment of common cancers with medications and surgery, it can't possibly work, and I'll explain to you why in just a minute. Now, to qualify this, I want to tell you that there are some early detection techniques that I recommend and I do think work. And these are detection techniques, screening methods that find changes in the body before they actually turn into cancer. So, that's before they turn into cancer. So I have recommended and still recommend that people get pap smears. I recommend, just like most gynecologic associations, same recommendation, I recommend that you get 2 negative pap smears and then you get a follow-up pap smear every 3 to 5 years until you get to be in your 50s or 60s. I say after 50 you don't have to get them. Most gynecologic organizations say after 60 you don't have to get them, and certainly you don't have to get pap smears if you've had a hysterectomy. Colon polyps. I recommend that you, not me, but you have an examination of your colon between the age of 55 and 60, because you can find precancerous polyps that can be removed, which I believe can reduce your risk of dying of colon cancer. Precancerous changes. So that's another recommendation I make. I also recommend that when you go to the dentist checks your mouth for changes that we call leukopenia, they're white spots that are precancerous, and that you check your skin. And if you see changes, you bring that to the attention of your doctor, because there is a phase of melanoma which I believe is curable. So those early detection or screening techniques I recommend. But those are cancers that are superficial, that can be found in a precancerous stage. There are also cancers that I believe we can effectively treat. So I want to qualify that. I don't want you to think that I say all cancer therapies are a failure. That's not true. Cancers that we do benefit with surgery, radiation, and chemotherapy are cancers like childhood cancers. Testicular cancer, we made tremendous progress. Lance Armstrong is an excellent example. Leukemias and lymphomas. But that represents about maybe 5% of the cancers out there. So what I'm going to speak about is not these less common situations of screening and kinds of cancers, but the most common ones. John C. Baylor, one of the most famous doctors and epidemiologists in the entire world, he published in the New England Journal in 1997 an article, "Risk of Dying from Cancer Has Increased," he said, 6% from 1970 to 1994. Increased. Remember, Nixon declared the war on cancer, we were going to solve the problem by 2000. He says, "The war against cancer is far from over. Observed changes in mortality due to cancer primarily reflect changing incidence or early detection. The effect of new treatments for cancer on mortality has largely been disappointing. The most promising approach to control of cancer is a national commitment to prevention, diet and lifestyle, with a commitment to rebalancing the focus and funding of research." That's what the true status is in terms of major cancers. We are losing the war on cancer. And our top researchers know this, regardless of what the campaign is out there to just send a few more dollars, the cure is right around the corner. On one of my television shows, I had an opportunity to have a couple of more of my heroes, people whose shoulders that I stand on. Charles Wright, one of the most famous epidemiologists in the world, was on my radio show, or my television show. And C. Barbara Mueller, if you are in the breast cancer surgery business, you know that this is the father of breast cancer surgery, C. Barbara Mueller. And they got together and they wrote an article based on their review of the effectiveness of mammography, and they published it in The Lancet, the best medical journal in the world as far as I'm concerned. And they published this in 1995, and their conclusion was, since the benefit achieved is marginal, the harm caused is substantial, and the costs incurred are enormous, we suggest that public funding of breast cancer screening in any age group is not justifiable. That's heresy. That's radical. Well, I still recommended mammography back in 1995. Well, not exactly recommended it, but I didn't discourage it. I discouraged it in women under 50. The majority of cancer organizations still say that it doesn't work in women under 50, and I discouraged it in older women too, because they're not going to live long enough to see the benefits. But between, say, age 50 and 68, somebody asked me if they should get a mammogram back in those days. I said, yeah, there might be some benefit, sure. Why not? But a report in The Lancet in 2000 changed my mind. This report was from a group called the Cochrane Review. The Cochrane Group is a group of Nordic researchers who are considered the most unbiased researchers. And they look at all kinds of issues in terms of health and medical care. They come to a conclusion that is respected by all doctors worldwide. In their publication, they say, in 2000, we reported that there is no reliable evidence that screening for breast cancer reduces mortality. That was the article that changed my mind, the article in 2000 in The Lancet. And then they say in this article in The Lancet, as we discuss here, a Cochrane review, that means a thorough official report, has now confirmed and strengthened our previous findings. The review also shows that breast cancer mortality is a misleading outcome measure. And finally, we use data supplemental to those in the Cochrane review to show that screening leads to more aggressive treatment, in other words, harm. Yeah. I stopped recommending mammograms for women in any age group when this report came out. Now, you could probably understand why mammograms may not be in the best interest of people and something you desire. After all, that's a machine that squeezes your breast between two steel jaws. It's painful. You may have heard about some of the controversy, but how could anybody object to just feeling the breasts, doing breast self-examination? Well, the validity of that screening technique has been evaluated. And it has been published in the Canadian Medical Association Journal in 2001, and it is a report from the Canadian Task Force on Preventative Health Care. They looked at the data, and they said 2 large randomized controlled, a quasi-randomized controlled trial, a large cohort study, several case control studies have failed to show a benefit of regular performance of breast self-examination or breast self-examination education compared to no breast self-examination. In contrast, there is good evidence of harm from breast self-examination instruction, including significant increases in the number of physician visits for evaluation of benign breast lesions and significant higher rates of benign biopsy results. What did they tell you? It doesn't work and it could hurt you just to check your breasts. In fact, their official recommendations, they made these same recommendations in all age groups. It's just like, let's read one of them. Women aged 50 to 59 years, because there is fair evidence of no benefit and good evidence of harm, there is fair evidence to recommend that routine teaching of breast self-examination be excluded from the periodic health examination of women in this age group. Shocking, isn't it? Yeah. So, for the majority of solid tumors like breast, prostate, colon, lung, the survival benefits from surgery are essentially none. Radiation, essentially none. Hormone manipulation, changing estrogen, testosterone, yeah, probably. I think so. Chemotherapy, very little benefit. Now, unless I explain to you why these findings are true, you may not believe them. But once you understand the underlying mechanism of what goes on, it's very obvious that present treatment can't work. This is the difficult part of the story. This is the part of the story that I've been hesitant to tell people unless I can really touch them and explain to them what's going on, because it's a very dramatic discussion, particularly if you understand the meaning of all this. First of all, the reasons that I tell you this natural history of cancer development is because I want you to win the war on cancer. I believe that if you know the truth, then you will win the war on cancer by prevention which does work. If you focus your attention on being saved, which is what we do, then you'll lose. That's the natural history of people. We do the easiest thing possible. Back 30, 40 years ago, if you were undisciplined in your sexual relationships, what happened? You got gonorrhea or syphilis, and you went to the doctor, you got a shot of penicillin. So free love was the name of the game back then. Today, if you're promiscuous, you get herpes and AIDS. And there's no cure. So people know that they have to change their behavior. So if somebody tells you they're going to save you by early detection and treatment from cancer, let's just take the easy way out. Let's not quit smoking. Let's not change our diet. When we get it, they'll fix it. But if it's not true, you've done a terrible disservice. So I want you to focus your attention on really what makes a difference, and that's prevention. They're not going to save you. Not for the majority of cancers. The second thing is if you do get cancer, I'd like you to choose conservative therapy. You know there's all kinds of ways you can treat cancer. You get breast cancer, you get a lumpectomy, you can get a modified radical mastectomy, you can get a radical mastectomy, you get radiation, no radiation, chemotherapy, no chemotherapy, hormone therapy, all kinds of things. Why do you have that choice? It's because it really doesn't make a whole lot of difference. Prostate cancer, watchful waiting, radiation, surgery, why do you get the choice? It doesn't make a whole lot of difference. Well, it does in the sense that you get a whole lot more complications if you go the aggressive route. If you got a stick stuck in your heart, nobody would say, well, let's debate on what to do. They'd pull the stick out and sew the heart up, right? Sure. But when it comes to therapies that are questionable in their benefits or actually been shown not to do any good, then you get choices. We'll put the guilt on you. So I would encourage you, if you do befall some of these cancers, you get minimal therapy. You get a lumpectomy. Or in the case of prostate cancer, you do nothing, is what I recommend, watchful waiting. Colon cancer, just have a local resection taken out. Now the third reason I'm going to explain to you the natural history of cancer is this, is I believe you can change the course of cancer by changing your diet. Like with smoking, if you get lung cancer, those fools who continue to smoke die at twice the rate as those who quit smoking after they find out they had cancer. Why throw gasoline on a fire? It makes no sense. If all of our major health organizations believe that prostate and breast cancer and colon cancer are caused by our diet, why isn't the first thing out of a doctor's mouth when you walk into the office, stop throwing gasoline on the fire, change your diet? I believe somebody who has one of these cancers, if they change their diet, they will live longer. I know they'll live healthier, but I believe they'll live longer. And I actually published the first study ever published in a scientific journal on the dietary treatment of breast cancer back in the early 80s. Since then, there have been many studies published showing the same thing. Even after you have cancer, if you change your diet, you will live longer. So, instead of a woman who has breast cancer dying in 3 years, with a good diet, lifestyle, maybe she'll die in 12. Instead of dying in 15 years, maybe she'll die in 40. My goal is to have everybody with breast cancer, colon cancer, and prostate cancer die of their cancer on their 95th birthday. Now let me explain to you why I have told you these things and what the reasoning is behind it. It has to do with the natural history of cancer, how cancer grows. Cancer starts as a single cell in the tissue. For example, let's take the breast. One cell in the breast changes. It stops acting normally. It becomes a cancer cell. And it starts dividing at a very regular rate. Now, the initiation for this cancer could be things like radiation or chemicals. Most cells that are damaged by radiation or chemicals or other factors in the environment, they die. But what happens is some cancers, they get hurt really bad, but they don't die. They just stop obeying the rule. And one of the important rules of cells is that you can't go dividing anytime you want. That's a very unneighborly thing to do. If cells divided at their own free will, at a rapid rate or any rate at all, at their own free will, we'd be misshapen lumps in a matter of hours. Cells are allowed to divide if you're to grow, like as a child, and they get specific instruction on how to divide. Or if you cut yourself, the neighbor's cells can divide and heal the wound. But otherwise, cells aren't allowed to divide. Well, if a cell gets injured, it loses that neighborliness and starts dividing at its own free will. And that's what happens with the cancer cell. So let's start with the first cancer cell in the breast or the prostate or the colon. It starts dividing at its own free will. And in a doubling time, which is an average of 100 days or 3.5 months, you have 2 cancer cells. Another 3.5 months later, you have 4 cancer cells. You've had cancer now for a year. You've got 8 to 12 cells lingering in a breast that contains 100 billion cells per breast. A prostate gland contains 100 billion cells. So you've got 10, 12 cells amongst 100 billion cells. You couldn't find that by any technique. Yet you have cancer. The divisions continue. 16, 32, 64. You've had cancer for 2 years. And you've got a tumor mass of less than 100 cells amongst 100 billion cells. You could never find those. And at these early stages, what happens is these cancer cells, they break out into the blood vessels, into the veins. And they spread throughout the rest of the body, and they lodge in the liver and the bones and the lungs. And there they divide at a similar rate to the original tumor. And those are the metastases. And those metastases are what kills. People don't die of breast cancer or prostate cancer. They die of cancer that's spread to the brain and replaces the brain tissue or has filled the lungs. That's what they die of, the metastases. And this starts at these stages in here. The divisions continue, and finally you get to a tumor mass of 1 million cells. It's the size of a period on a paper, a lead tip of a pencil. It's undetectable by any method that we have, and yet you've had cancer for 6 years. And if it's truly cancer, unfortunately a lot of people who are told they have cancer, it's not really cancer. But if it's truly cancer, it's spread in essentially all cases. The divisions continue, and finally you have a tumor mass of 1 billion cells. It's the size of an eraser of a pencil. It's now detectable by digital rectal examination or breast self-examination. Actually, tumors detected by mammography are usually a little later on. They're usually around 12, 14 years in their growth when they're detected. It has to do with the fact that tumors that grow more rapidly, the woman usually finds them herself, whereas the mammographically detected tumors are slower growing and you don't find them until they get around 12 to 14 years in their growth. So the problem here is that by the time you've discovered that you have a tumor, 2/3 of the disease has already occurred unbeknownst to you or the doctor. The disease has already determined its course. In more familiar terms, the cattle are already out of the barn before you close the door. And that's why no matter what you do to the breast, radiate, surgery, or the prostate, you're not going to affect the eventual course of the disease because it's a systemic disease. It's all over the body. And that's why chemotherapy has become so popular, is the doctors know this. And so they've tried to attack the tumor throughout the rest of the body. What I believe is this, and the important thing for you to understand is I believe that this doubling time can be changed. I believe by a good diet you can invoke a healthy immune system that will slow this doubling time so that instead of your tumor mass doubling every 24 days, it doubles every 800 days, and by the time it reaches a critical size, you're 176 years old. Okay? And the scientific research supports my beliefs. And if you want to read about the natural history, as I described it exactly here, you can read about it in the Journal of Surgery Oncology 1997. There's a 40-page article that will tell you that this is exactly how it occurs. And every well-trained doctor knows this. So there are diet and lifestyle changes that could make a difference. For example, you can decrease the risk factors of getting cancer and cancer progressing. People who are overweight get more cancer and their cancers grow more aggressively. You can lower IGF-1 levels, that growth stimulant, which predicts whether you're going to get cancer or how fast it's going to grow. You can lower your cholesterol and your hormone levels by dietary change. In one study published in JAMA in 1995, it showed that physical activity, walking 3 to 5 hours a week, reduced the absolute, not relative risk, but absolute risk of death in women with breast cancer by 6% over 10 years. That compares with chemotherapy results, and is far better than radiation or surgery, just by taking a walk. And then we did the Women's Initiative randomized controlled trial, and unfortunately that was a failure. Ernst Winder and Rowan Chablowski are people that I know professionally well. I've had both of them on my radio show and Rowan Chablowski on my television show. And every time we went through the discussion, we'd get to a point where I'd say, why are you feeding these people a high-fat, high-cholesterol diet? Because what's going to happen is at the end of the day, you're going to show no benefit because it's not a healthy enough diet. You need to feed them a diet like I'm recommending. And of course, they poo-pooed the idea, and they said, no, it'll work out. Well, at the end of the day, what they found out is those who followed the low-fat diet lost 1 pound more than the control group. They didn't follow a low-fat diet. But even with the minimal benefits that they accomplished in these women in terms of dietary change, on the average, there was 9.8% women on the low-fat diet who had a recurrence in 5 years. And those on the standard diet had a higher, a 12.4% rate of recurrence. So even the little bit of change that they affected in these women made a difference in their survival. And one more serving of fruits and vegetables daily resulted in a 9% reduction in the risk of getting breast cancer, those on a low-fat diet. They blew it. Tens of millions of dollars spent, and they blew it because they weren't willing to give patients a full dose of medication. They gave them a diet that they thought was reasonable, sensible, moderate, but ineffective. All right, this is where we're at today. The emperor has no clothes. The problem is that lifestyle medicine has been proven to work well, and it has no side effects and essentially no costs. And people are starting to realize this, and current drug and surgical treatments are not working. The treatment of chronic disease with diet and lifestyle can't possibly fail. I want to see if we could agree on a few things, okay? Some of you are doctors, all of you are patients. I want to see if we can come to some common agreement on some issues here. I was at a restaurant several years ago, and a lady came up to me, and she said to me, I'd like to take a picture of your family. And I said to her, I don't really want a picture of my family, but would you take a picture of this family sitting over to my left? And she went over there and took a picture of this family and came back and sold it to me for $10. These were women who were speaking Japanese, obviously from Japan, first and second generation at most, eating mostly rice and vegetable dishes at this restaurant. And I said, that was pretty neat. I wonder if I could do that again. So she sold me the picture for $10, and I said, now could you take a picture of that family sitting over there? And she went over and she took a picture. And came back and sold it to me for $10. Now all these people I showed you are Japanese. But can you tell the difference? This is third and fourth generation Japanese that are speaking pidgin English. Now what happened to the people between the first and second generation and third and fourth generation? Did they catch a virus? Did they change their genetics? What happened to them? They ate less rice and more fat and more protein and more meat and more dairy products. That's what's happened to them. Now, what would happen if you took these people here and you gave them a one-way ticket to Japan and put them to work in a farming family in a village and fed them rice and vegetables and had them work in the fields all day long? They'd get trimmed, they'd get off their medication. That's what would happen. They'd get healthy. That's essentially what we do with this program, is we give you a one-way ticket to Japan, but a lot tastier. And you can see this worldwide. This is not an observation that's only held by scientists or researchers. Just go down to your international airport and look at people. You see people that come from the Middle East or the Far East or Africa. They're trim, healthy, hardy people with very low rates of heart disease, rheumatoid arthritis, breast cancer, colon cancer, prostate cancer. They have some of their own problems related to sanitation, lack of medical care, things that we've solved in our country. And you watch what happens when these people from the Middle East or Asia or Africa move to the United States or Western Europe. They adopt our diet and lifestyle and they get fat and sick. You know this. This is no mystery. So we'll send these people back to Japan with a one-way ticket and we'll get them healthy. Unfortunately, too few people would like that kind of treatment, but that's what would really work. As I said before, we succeed with acute care problems. And the reason we succeed with acute care problems is acute care problems are due to single injuries to the body. Like we cut ourselves and we go to the doctor sews up the wound, and everybody's happy. The patient's happy, the doctor feels like he or she has done a great service. It's a wonderful relationship. You break a bone, the doctor straightens out the bone. The healing occurs more rapidly and much more normally when you set the bone. You get an infection, the doctor comes in and lances the abscess. Everybody's happy about that relationship. But what do all those things have in common? They're due to single injuries to the body, and the medical business intervenes and makes a huge difference. When it comes to chronic disease, the problem is that this is caused by repeated injuries to the body. For example, I used to have a terrible disease. I had a horrible cough. I used to wheeze. I was short of breath. I couldn't walk up hills when I was in my mid-20s. I went to the doctor. The doctor gave me acute care solutions, gave me antibiotics, cough syrups, wheezing pills, and I stayed sick until I dealt with the problem. The problem was I was injuring myself 40 times a day with Marlboro cigarettes. And you've had this experience. I know many of you had. What happened a week later? You were cured. So what we need to do now is we need to identify what the cause of repeated injury is. This is the cause of repeated injury. It's 4 or more feasts a day. Every day in our country, we start out with Easter for breakfast. We go on to Thanksgiving and Christmas for lunch and dinner, and every night after dinner we have a birthday party. Eating that kind of food in the past resulted in aristocrats, kings and queens, fat people with gout in their feet. The difference is we just have more kings and queens. People eat at Burger King and Dairy Queen and Imperial Margarine. They don't even try and disguise what's happening. 5 of the 10 leading causes of death, chronic diseases, are due to our diet, and that's what the Surgeon General says. Heart disease, cancers, strokes, diabetes, and other forms of atherosclerosis. So here we can make a huge impact. Now let's see if we can agree on something else. Say you're a doctor, and you're practicing good medical care. This person comes to your office with a terrible, terrible cough. Can hardly breathe. What's your solution? Smoker's vitamins? Cough syrup? Of course not. That's not what a good doctor would do. This is what a good doctor would do. Tell the patient you've got to quit smoking. Now this person comes to your office. A chronic alcoholic. You give them pills for the fluid accumulating in their abdomen as a primary treatment. You give them extra vitamin pills. What do you do for this person? It's obvious. You stop the destructive behavior. Now what happens is this person comes into a doctor's office. And how does the medical profession respond? I'm not talking about half the medical profession, or 75% of the medical profession, or 98% of the medical profession. I'm talking about 99.99% of the medical profession. How do they respond? They fill their medicine cabinet with bottles of pills and never deal with the underlying problem, and that's wrong. There's a book I just recently read. Have you read it, The Kite Runner? It's a great book. You ought to read it. In the discussion in The Kite Runner, one of the characters says, now, no matter what the mullah teaches, there is only one sin. Only one. And that sin is theft. Every other sin is a variation of theft. Do you understand that? He goes on and says, when you kill a man, you steal a life, Baba said. You steal his wife's right to a husband, rob his children of a father. When you tell a lie, you steal someone's right to the truth. When you cheat, you steal the right to fairness. Do you see? Well, carrying that logic over, when you misrepresent the benefits and risks of medication, surgery, and other popular treatments, then you steal a patient's right to health and happiness and their money. When you fail to inform somebody about the importance of lifestyle medicine, then you steal that person's right to live free of sickness and medication. Yes, you do. I don't know any other way to tell it to you. That's what you do. Lifestyle medicine is the standard of care for diseases that are caused by diet and lifestyle. And doctors should be criticized and penalized for using drugs and surgery when a change in diet and lifestyle would achieve similar, even better medical outcomes. This is wrong. If you have a dietary and lifestyle disease and you go to the doctor and that doctor fails to tell you that and gives you drugs instead, that would be similar to you going to a doctor with heart disease and that doctor failing to tell you about beneficial surgeries or drugs if they did exist, and you end up dying. What excuse could a doctor have for not offering you these effective treatments? The doctor would be penalized and sued, or maybe worse, and deserve it. Well, the same thing is happening every day in almost every doctor's office throughout the Western world, as people are being deprived of their right to know the truth. And doctors should be penalized and criticized for that. I do believe it. Well, what about people unwilling and not able to change? Well, you know, if you can't solve all the problems, and I can't, I told you I have a prescription pad. I write prescriptions for medications. Happens to last about a year, one prescription pad for me, but I do write prescriptions. I'm an internist. I like to think of my practice as very conservative medical practice. I am not an alternative doctor. I am not a holistic doctor. I'm just a regular doctor who practices a conservative form of therapy based upon evidence. And so you need to prescribe medications judiciously, but the first approach needs to be diet and lifestyle. So, when it comes to medications and making a living, I have something very important to tell you. Is I have a medication for you, and Mary has it for sale at the back of the room. I have these special pills, and we sell them for $2.45 a piece. And because I like you, I consider you my friends, I'll tell you what the ingredients of these pills are. Each pill contains a half a gram of dried powdered banana, 2 flakes of Quaker oats, 1 broccoli flowerette, 1/4 of a kidney bean, and a half a small dried potato eye. And you have to take 2 of these a day until our mortgage is paid off. Okay? Now, some of you're wealthy and you really want the high potency stuff. So we do have a high potency variety, an enhanced formula. We sell those for $12.95 a pill, and the additional ingredient is 3 sesame seeds. You know, I do believe I'd get more people to follow our diet and lifestyle recommendations if I had these for sale. But the qualification here is these pills don't work unless you do change your diet and lifestyle, because that's what really works. Thank you very much.